Welcome to the ACCESS Summer Trainee Symposium. This year, ACCESS, yeah, there we go. So this year, ACCESS had a summer experience for trainees working in the Canadian pediatric cancer space and or working with an investigator involved with ACCESS to create an inclusive and positive experience. The summer experience arranged for weekly gatherings that included meet and greets with ACCESS's executive director and co-chairs, and bi-weekly meetings, which were presentations on topics of interest, and the trainees could present to one another. Today we have our Summer Trainee Symposium. And today we'll be hearing from the trainees who will be presenting on their work and projects from over the summer. The trainees will have 3 minutes to present with a Q&A period afterwards. Just some housekeeping. So during the question and answer period, please type in your question into the Q&A function on Zoom, selecting the host and panelist selection. When it's at the Q&A period, the names of the presenters will be listed on screen during the period. So please specify which trainee your question is for.
Hi, my name is Robin Cruz-Abrams, and I'm a summer research student at Sick Kids working in the Denver lab this summer. My presentation today is on the research I've been doing about how Canada's Drug Agency conducts their pediatric drug review. Next slide, please. So for some background, few drugs are developed and approved for children. So Canada's Drug Agency conducts the health technology assessment, and they look at cost effectiveness. So this occurs after drugs have been approved for safety and efficacy by Health Canada. And so our research project looked into Canada's Drug Agency's role in this whole drug access pipeline. Next slide, please. So to do this, we looked at the publicly available documents on the CDA website, which outline their recommendations and their decision-making process for those. We looked at all the documents available for recommendations for drugs. And from all the recommendations since mid-2017, because that's when the most recent document format was created, we extracted the data for drugs that had indications including pediatrics. And that data included categories such as cost, manufacturer, and then the timeline for the recommendation process, as well as many more. After doing that, we extracted qualitative factors about economics, evidence, and ethical, legal, social, and implementation factors to see how those were discussed in the recommendation decisions. From there, we conducted qualitative analysis and thematic analysis to see what themes are commonly brought up in these recommendations for the pediatric population. And this is an iterative process, so this didn't all just go in order, but we go back and forth as we found certain themes that were coming up pretty often. Next slide, please. So here are some preliminary results. On the right, you can see how few recommendations from the CDA have indications for pediatrics. Out of the total 442, 361 of those only had indications for adults. So there's very few for pediatrics. And on the left, we have some of the common topics brought up during the recommendation discussions. So this was a big part of our research. We've grouped these topics into 3 categories. The main factor which sways decision-making in general is clinical evidence. If there's not sufficient clinical evidence, drugs will not be approved. So that's a very important category. And oftentimes we saw that adult data was being extrapolated to allow the pediatric population to be included in recommendations. So this was brought up very often. And in the economic impact category, there was a lot of discussion around high prices, especially for drugs for rare diseases, for pediatrics. And there was concerns about medication wastage if there were the one-size single-use vials, which held more medication than pediatric patients needed. So then some medication would be wasted. There was also a lot of conversation about around unmet needs for certain diseases. And so we plan to continue our analysis, and we hope that our results can inform how the HTA process in Canada can evolve in the future to cater more to the pediatric population. Thank you.
Intezar? Oh, you're muted.
It's 8 a.m. on a Thursday. You've just arrived at the hospital after a 2-hour drive for your child's oncology appointment. You got up at 5 a.m. to be there on time, and both of you can't even remember the last time you were this tired. Except, of course, yesterday and the day before that, because that's how it feels every single day. If it's not another early appointment, it's trying to find time for the billion other things that come with a childhood cancer diagnosis. Sleep is the last thing on your to-do list, and far above getting your own rest is trying to help your child get through their sleepless nights ever since they got sick. Unfortunately, this is the exhausting reality of many childhood cancer patients and their families. Treatment is incredibly demanding on all aspects of life, which can drive parents and children to struggle with their sleep. We know that poor sleep is damaging in the long term. It can hinder the psychological and the physical components of recovery for the child, as well as the parent's ability to provide care and to cope with the implications of their child's illness. For this study, we saw a need to investigate the factors which may be affecting their sleep outcomes. In recent years, home treatment programs have emerged with the goal of decreasing burden on patients and families. We wanted to see if there were any changes in sleep outcomes when treatment is offered in the home compared to the hospital. Perhaps the stress and time commitments associated with hospital visits, or maybe the burden of care in the home, may be contributing to altered sleep quality. To answer this question, we sent out questionnaires to the caregivers of 11 pediatric cancer patients receiving treatment at home and 11 in the hospital. And caregivers were reporting on both themselves and their child. The most shocking finding was that 100% of the children were experiencing disordered sleep and 84% of the caregivers. The problem we were suspecting in these families was coming into focus. Their sleep is suffering and actually remained unaffected no matter where treatment was being provided. In light of this, our next step was to explore other variables which may be contributing to this very prevalent sleep crisis. From our questionnaires, we found that child treatment anxiety was a predictor of poor sleep for both parents and children, while poor family functioning, including parental physical health, was linked to poor sleep in parents. As these factors consistently correlated with poor sleep quality in both home and hospital-based care, it was clear that addressing them through a long-term psychosocial intervention will be crucial. Targeting patient anxiety and family functioning has the potential to significantly improve sleep quality for both children and their caregivers, ultimately enhancing their well-being and their resilience in the face of childhood cancer. We feel that future research should focus on these interventions to determine their effectiveness in bringing a better night's sleep to those who need it most, so that families facing the challenges of childhood cancer are supported in every possible way. Thank you.
Simone?
Hi, my name is Simone Garneau, and I'm going to be presenting on a qualitative examination of pain in adolescents and young adult survivors of hematopoietic stem cell transplants as treatment for sickle cell disease. So sickle cell disease impacts over 6,000 people in Canada, and life for those with the disease is marked full of challenges. Sickle cell disease is a genetic disease that causes one's red blood cells to become stiff and crescent-shaped, leading to severe blockages in blood flow and frequent excruciating pain crises, among other symptoms. One of our participants recounted their first experience with sickle cell pain in their chest. They shared, "The first time I had this pain, I thought I was having a heart attack. The first time my dad saw me like that, he was so scared. He was trying to be brave for me, but he was just so scared. I would just lie down on the bathroom floor throwing up because of the pain." The pain experienced by sickle cell has been described as agonizing and limitless by those with the disease. Sickle cell pain interference, frequency, catastrophizing, and chronicity are all linked to poor health-related quality of life. And many with the disease feel that they just have to accept that their disease is incurable and learn to live with the pain. However, advancements have been made that offer hope for a different future. Our study explores the experience of adolescents and young adults who have undergone hematopoietic stem cell transplants, a procedure that can cure sickle cell disease. The first transplant only occurred 40 years ago in 1984, but as of 2022, 1,200 have been conducted, with 38 having been at the Alberta Children's Hospital. In our study, these transplants were described as life-changing, not just for those undergoing the transplant, but for their families as well. The picture on the screen is of a young woman named Reve. She's the first adult in Western Canada to undergo the transplant to cure her sickle cell as an adult. Reve shares her story on social media, and in one of her posts, she said, "Today I stand as living proof that there's hope beyond the pain." This quote illustrates the impact a transplant can have on individuals, emphasizing the possibility for a pain-free future that many with sickle cell disease never thought possible before this treatment came along. However, our interviews revealed some challenges associated with the transplant, such as unexpected pain and lifestyle changes post-transplant. So while the transplant offers hope to many, we still don't know how life exactly looks after this transplant. We aim to address this gap. Our study involved interviews with 11 child-parent dyads who have undergone the transplant, and we aim to capture the full scope of their pain experience from living with sickle cell disease, going through the transplant process, and into their new lives post-transplant. We are utilizing interpretive phenomenological analysis to interpret our data. This method allows us to understand each participant's unique experiences before identifying broader patterns. Our preliminary analysis has covered groups of codes such as parental impacts and child guilt, pain and identity transformation, transplant pain and health memories, transplant side effects and concerns, support systems and care, and post-transplant normalcy. As we continue our research, our goal is to highlight these narratives and to advocate for better support for children undergoing these transplants and their families, and to show both them and healthcare providers how challenging but also life-changing this procedure can be. Thank you.
All right, thank you so much. So now it's the question and answer period in the chat. So this is for Robin. Have you looked at how other countries approve access to pediatric oncology drugs?
Thank you. That's a great question. So actually, our research was inspired by a similar study by NICE, which is the UK's HTA body. So they're the main other country we looked at, and they have a similar proportion of pediatric versus adult indications for drugs. So not as many pediatric drugs. Yeah, and other than that, we haven't looked into a ton of other countries, but there is a wide variety of, some countries have specific recommendation processes for pediatrics, and some don't even, like some Scandinavian countries don't even look at age when making funding decisions. So it really varies, but NICE is the main other HTA body we've looked at.
Thanks, Robin. Were there any other questions from attendees? Oh, and this one is for
Jenna, I put one in.
Go ahead. Would you like me to read it, Dr. Whitlock?
Or can I just ask it?
For sure. Yeah, go ahead.
Okay. So actually I have several questions for different people. So for Denise, so based on your work, what do you think is the single biggest obstacle to being able to improve the utilization of PROS in children with cancer? If you could change one thing, what would be the most impactful?
I think that probably the step that would be most impactful is awareness and education for the pediatric oncology community in terms of how about patient-reported outcomes. I say this because I believe that there are already quite a lot of useful tools that can be utilized at each stage within the clinical trial life cycle to incorporate PROS into protocols effectively. But if we are unaware of these tools and if we're not bringing them into practice, then I don't think we will be able to move forward. And I believe that because protocol design and reporting is often the first step in advances in clinical treatment for hematology and oncology, that focusing on the protocol design and development piece and education relating to that would help move it forward.
Great, thank you. Robin, if you were in charge of the CDA, what would be, do you think, the single thing that you could change that would most benefit children with without sort of going outside the guardrails that CDA has in place?
Yeah, that's a great question. So I think that as a part of the Denver Lab, they've created this catch framework, which includes like a lot of things, a lot of values that they think are really important to look at when looking at pediatric drugs. So this includes caregiver impact and long-term life development impacts. And so I know they're currently piloting that and trying to have the HTA look at that in their recommendation process, but I think that I would try to get a framework for specific values that the CDA could look at when they're looking at pediatric drugs, and I would try to have them implement that. So it's not just the same recommendation process for everyone. So it's a little broader, but that's the way I would go with that.
Great. Thank you. This is for Intisar. Look at the issue of screen time in your study of sleep disturbances in children with cancer. Is there any information in that particular population to suggest that how much time they spend on the screen at night, or their access to screens and social media? Does that seem to play any role in sleep disturbances?
Yeah, so in this study, we didn't look at screen time. It was more so we were trying to find relationships between, different aspects of these children's well-being, specifically related to their cancer. So things like anxiety and procedural anxiety, treatment anxiety, relationships with family, that kind of a thing. But I do think that would be really interesting, because especially now, I think there has been quite a bit of research or quite a bit of interest in how screens are affecting children in general. And so I'd be quite curious to see how that might translate into the pediatric cancer space. I mean, especially because their lives look a little bit different, and maybe some of these school-aged children might not be in class as much. They might be trying to catch up on computers and whatever, or maybe trying to supplement their relationships with their friends more on the screens. I'd actually be quite curious to see what that would look like, actually. Yes.
Great, thank you. Yeah, I think you're right. This is it's a prevalent issue across society. I'm not aware of any data specifically in the pediatric cancer population, or whether that could be modified or not.
Yeah, of course, for sure.
And then for Simone, given what you've learned and seen about the benefits of hematopoietic stem cell transplant in patients with sickle cell disease, are you ready to advocate that every patient with sickle cell disease should get a hematopoietic stem cell transplant as curative therapy?
That's a really good question. I don't know if I'd advocate for everyone to get it, because there are lots of complications that we've been learning from the study that people aren't really aware of some patients have lasting damage from their sickle cell disease that they didn't really fully realize would carry over. And also getting the transplant is very difficult, because you do need a donor match. And that is a huge problem in sickle cell right now, is it's very hard to find a donor match. Of everyone in our study, they had their donor match was a sibling match. But if you don't have a sibling match, it is virtually impossible to get this transplant right now. But from what we've heard, it is a very miraculous cure for sickle cell disease. And what we know so far, lots of these people, their lives have been changed. So I feel like I'd have the very lukewarm answer of people telling them to look into it and see if it's right for them.
Perfect. Great. Thank you.
Were there any other questions for this group? Checking. All right. So up next is Rachel.
Good afternoon, everyone. My name is Rachel Hamilton. I'm a registered nurse at SickKids and a PhD student at the University of Toronto. Today, I'm going to be presenting my ongoing scoping review entitled Patient and Family Caregiver Perspectives on Therapy De-escalation in Cancer. Long-term cancer survival rates for many cancers continue to rise in large part due to treatment advances driven by clinical trials. Typically, treatment improvements focus on adding more, often novel drugs. However, cancer treatments are not without detriment, with limitations including immediate side effects, short-term toxicities, and chronic, and in some cases, life-limiting long-term effects. Patients across ages and cancer types prioritize minimizing these effects. Cancer therapy de-escalation embraces the goal of giving less treatment to minimize toxicity without change in survival. Despite the potential positive impacts, there's a sobering risk of undertreatment, which may result in treatment failure, relapse, or death. This uncertainty can make it particularly difficult for patients and their family caregivers to decide whether or not to take part in a de-escalation clinical trial. The preferences and values of potential participants greatly impact their decision. It is crucial to understand the factors that optimally design and recruit for clinical trials. The objective of my current work is to synthesize the literature about patient and family caregiver perspectives of cancer therapy de-escalation. Preliminary results show that patients and family caregivers strongly consider 4 factors when making decisions. Informational needs, so the patients and family caregivers value knowing important information such as survival rates, why the trial is being offered to them, and making sure that they understand all of their options. Patients and family caregivers' values and preferences are also important in decision-making, with particular recognition to altruism and giving back to the research community, and whether they are raising a family. Uncertainties about fear of recurrence and decisional regret often impact final decisions. And finally, it was noted that patients and their family caregivers put a lot of trust in their providers, trusting their recommendations of the team. Overwhelmingly, studies in this review focus on adult patients, with only 20% looking at pediatrics and only 25% mentioning caregivers. There is a clear gap in knowledge about de-escalation in the pediatric context. We need more information about what pediatric caregivers need in order to make decisions regarding de-escalation of cancer therapy. My future work will focus on determining what decisions caregivers of children with cancer make in regards to de-escalation, and will explore factors that influence these decisions so that future caregivers are adequately informed when making difficult decisions. Thank you.
Thanks, Rachel. Over to Emma.
Hi, I'm Emma. I'm a summer student at the Care for Kids lab in Calgary. Overcoming childhood cancer should not only be about surviving, but about thriving. Today, I will present a glimpse into the mental health experience of young survivors who have battled acute lymphoblastic leukemia, or ALL, and solid tumor. Survivors of childhood cancer are extremely resilient, and this population continues to grow due to medical advancements. But their fight does not end when their treatment does. Survivors continue to endure debilitating late effects, including psychological distress. In my study, I set out to explore the mental health of survivors of ALL versus solid tumor. I wanted to uncover whether type of cancer and different treatment processes endured by the survivors influence their anxiety and depression levels, as is expected. I also attempted to identify the impacts of poor parent mental health on children, which has been previously linked to increased cognitive, emotional, and social risks. To do this, 18 survivors of ALL and 24 survivors of solid tumor were recruited from a long-term survivor clinic. Children and their parents completed anxiety and depression questionnaires from the Patient-Reported Outcomes Measurement Information System, or the PROMIS. Surprisingly, results indicated that the levels of anxiety and depression symptoms did not differ significantly between the ALL and solid tumor groups among the children themselves. However, the parent mental health results revealed that for survivors of solid tumor, higher levels of parent depression correlated with increased depression symptoms in their children. Although there were no statistically significant differences discovered between the two groups of survivors themselves, investigating the data further revealed some critical insight. While only 10% of survivors of ALL scored in the moderate to severe range for anxiety, 33.3% of survivors of solid tumor scored in this same range. Similarly, for the depression symptom questionnaire, only 6.7% of survivors of ALL scored in the moderate to severe range, compared to the 29.2% of survivors of solid tumor. The disproportionate volume of survivors of solid tumor scoring higher for both anxiety and depression suggests a clinical significance that should be considered and further investigated. I aim to continue to explore previous literature and my own data to understand why there is a higher proportion of survivors of solid tumor experiencing more severe psychological symptoms. By gaining a more comprehensive overview of protective and risk factors, we can simultaneously begin to establish new interventions to better support these children on their journey of survivorship. This will help us to move closer to a framework that allows children to not only survive cancer, but to thrive in every aspect of their lives. Thank you.
Alicia?
Hi, everyone. My name is Alicia Kilfoy, and I'm a registered nurse at SickKids and a PhD student at the University of Toronto. And today I'm going to be talking about my PhD thesis, which is entitled Co-Design of a Resilience Promoting Mobile Health or mHealth Intervention for Parents of Adolescents with Acute Lymphoblastic Leukemia or ALL. Next slide. So parents of adolescents with ALL, historically aged 13 to 18 years of age, experience unique psychosocial challenges compared to parents of younger children with ALL due to their child's age and developmental stage. These challenges include but aren't limited to the fact that they have to encourage self-management skills in their child while also simultaneously caring for their very sick teen. They have to navigate communication challenges with healthcare providers and their adolescents and support their teen through challenges related to education, intimacy, and fertility. This clinical picture is further compounded by the fact that the population reports feeling under-supported in a clinical setting and is under-researched in the literature. Together, this situation results in elevated levels of anxiety, depression, and traumatic stress within the population. Expression of positive psychosocial constructs, including resilience, have been shown in the literature to longitudinally improve quality of life in parents of children with chronic conditions, including cancer. Resilience can be defined using a number of different definitions. However, the one that I always choose to present on is that resilience is the process of adapting well in the face of stress or adversity. There are currently a number of resilience promoting interventions available for parents of children with cancer. However, there are several concerns related to these interventions, which I just want to highlight. First, they're often provided in an in-person format, which raises concerns around accessibility. As we all know on this call, unfortunately, these families often face time constraints due to family and treatment-related demands, and expecting them to attend an intervention in person limits the feasibility of the intervention. Further, these interventions are often not tailored for parents of different age groups or different diagnoses, and this is of concern given the unique challenges that these different subgroups face. And then lastly, these interventions are often not co-designed alongside parents. And co-design is a process in which intervention end users are actively involved in the design and development of the intervention. Co-design in the literature has been shown to improve intervention effectiveness and long-term sustainability. So my PhD thesis is really aiming to address these gaps and co-design with parents a tailored resilience promoting mobile health intervention for parents of adolescents with ALL. This work is really aiming to specifically design an intervention which is needed for an under-researched and under-supported population. And ultimately, we're hoping to improve the quality of life and decrease known long-term psychosocial consequences of an ALL diagnosis in parents and subsequent family members. Thank you.
Alex?
Hi. So my summer research project is on understanding patient needs in advocacy and research partnerships. And my supervisor is Dr. Mira Rayar. Next slide, please. As part of Matrix 5 Aim 1, we're looking at patient involvement in pediatric care and research. So 4 of the main goals that we have are first, to provide training to patient advocates. Second is to create a centralized learning hub. Third is to create this national patient navigator program, because there's not really much centralized resources for pediatric oncology, and as well as creating a patient learning institute. Next slide, please. So in regards to my project, I'm developing a needs assessment. So essentially what that is we're looking at what are the gaps, what is missing when somebody wants to get into advocacy for pediatric oncology or would like to participate in research. So I'm working with a group of peoples with lived experience just to understand, hey, like what intentions with advocacy? How'd you get into it? And how can we create resources that would improve your work and your career in advocacy? And yeah, so we'd send out the survey and understand a little bit about that. And hopefully at the end of the day, we're going to be creating a learning management system through D12 and figure out how that's how we can best create a course for this group of people. Next slide, please. So in terms of building a needs assessment, there's like a couple of key groups of things that we have to take into consideration. So the biggest challenge I've had this summer is the inclusion criteria, as well as like figuring out wording that is appropriate, especially since we're trying to target a huge range of people of different educational backgrounds, and as well as making sure that what we're asking is non-triggering. And secondly, a big thing we need to know is like how to phrase each question to actually figure out what we want to know with the least amount of wordage, because nobody wants to sit there for 20 minutes to read a quiz or some Qualtrics form. And there's a bunch of validity concepts as well that that we have to take into consideration, including predictive validity, just to see like how can we predict, like, is this actually of use for a broad range of people. Next slide, please. So essentially, this is the working timeline we have. So we're still undergoing REB approval for this form. And eventually after that, we'll be able to talk to BC Children's, the ACCESS Network, POGO, and really figure out, hey, like, can you guys just send this out to as many people as possible to get the most reach? And eventually, we hope that this is enough for building our course and eventually the Learning Institute. And yeah, if that's not enough, we might consider using a nominal group technique, more so like focus groups, to make sure that we're getting all the information that we need. Thank you very much.
Thanks so much. So we have a question in the chat. So this is for Rachel. Have you looked at what the healthcare teams thought on de-escalation for families? If proven it works, but healthcare teams are against, how is this going to influence families' decisions?
Hi, that's a really good question. Thank you, Kirsten. So, I mean, just like patients and their family caregivers, obviously, everyone has their own unique kind of risk-taking preferences. And you're totally correct that these kind of conversations can have inherent biases kind of passed along, kind of opposite to what you're saying, in that if they're against it. But something I found in my review, one study said that if a physician is for de-escalation, a patient and family caregiver are twice as likely to select de-escalation. So there's obviously some kind of sway or influence that these conversations have. So I think it introduces the idea that perhaps some sort of kind of training or lessons on how to communicate these kind of ideas to patients and family caregivers is necessary, as well as kind of this reflexive practice of making sure you have your own perspectives in check before you're having these conversations.
Thanks, Rachel. I think there was a question from Trisha. Do you want to unmute?
Yes, thank you. So this question is also for Rachel. So in my previous work life, one of the trials I developed and oversaw was a de-escalation trial on surveillance for lung metastases after surgery for an extremity, or like soft tissue sarcoma. So that's a soft tissue sarcoma that occurred in the arms and the legs. But prior to developing the clinical trial, we conducted a survey of patients to understand whether they would even participate in a trial like this. And the overwhelming response was yes. But in spite of finding that patients would participate in such a trial and successfully obtaining $750,000 for the pilot phase of the trial. We were never able to successfully obtain funding for the definitive phase. As such, the trial is now going to soon close to recruitment. They've adjusted the sample size and are about 30 patients away from meeting their new goal. And so have you considered that the opinions, values, and preferences of importance to your project extends beyond patients and caregivers to include funding agencies?
I think that's a really valuable point, because as you're saying, even if people are on board, if there's no one to kind of get these trials kind of up and running, what's the point? I think that kind of my work prioritizes the patient and family caregiver. It sounds like kind of work that you've kind of done as well, but a lot of kind of these de-escalation trials don't look at patient and family caregiver perspectives first. I think that's really amazing that you guys have done that kind of before starting, but I think it's more common not to. So I think kind of the first step is kind of getting the patient and family caregiver feedback to make sure that the trials are feasible. But then certainly once that's done, I think finding out kind of what makes a trial feasible from a funding perspective is really important, because that's the way forward. That's how we're going to get these trials kind of underway on the bigger scale.
Great, thanks. There was a really interesting editorial in the New York Times that was published last year on de-escalation trials. I'll send you the link to it in case you're interested in it.
Thank you so much. That's fantastic.
Thanks, Trisha. Christine, I see you have your hand up.
Hi, everyone. My question's for Alicia, but I just wanted to say in general, these are really great talks and really great slides. So we're going to tap all of you for slide design in future. Alicia, I was just interested in the development of the way in which the mobile health intervention was being developed. And you talked a lot about co-designing it with parents. And I just wondered what the role of adolescents themselves might be or could be in the design of that intervention, given that they're older than really young kids. And I'm going to bet all of them are pretty mobile phone savvy.
I think that's I think that's a great question, and something that I've thought a lot about with my supervisor and had some back and forth with her about. I think as just a starting block, we're really going to focus on the parents themselves, because previous work from our lab has really shown that parents want an intervention specifically for them. But I think in future iterations, it would be really neat to incorporate adolescents and kind of have adolescents have maybe their own profile available, which can they can log on to themselves and either kind of communicate with their parents through that app safely, or kind of have access to similar resources that are more adapted to adolescents. But right now we're focused more specifically on the parents themselves, but long-term would love to kind of adapt it to include the adolescents as well.
Dr. Whitlock, I think you had some questions.
Yeah, I have a question for Emma. So Emma, your data suggested that perhaps there was more anxiety and depression in patients with solid tumors than ALL, although you did point out that that's not statistically significant. Do you have any insights or guesses as to why solid tumor patients and their caregivers might have a higher level of anxiety and depression than patients with ALL?
Yeah, it was definitely a surprising result, because I was expecting the results to be opposite, just because of the CNS-directed treatment that ALL patients receive. But I am wanting to do a little bit more research, kind of digging into the specific diagnoses that the survivors that we specifically looked at had, and see if maybe there's something physical that has been changed about them. Maybe they look a little different than the kids in their class. Maybe they were gone for longer periods of time because of the treatment that they had to receive. And just kind of looking into whether it is something specific to their treatment or if these kids just happen to be in a different environment than the ALL survivors, and understanding whether it is like a treatment factor or if it is something else like parent mental health, family. So I'm not too sure at the moment, but that is a really great question, and it is something that I plan to continue to look into as I continue my research.
I would encourage you to look at what the families are told about the prognosis of those diseases. ALL is one of the most common. It's also one of the most curable, whereas with many solid tumor patients, there haven't been meaningful advances in 30 or 40 or 50 years. And so maybe the knowledge of their child's expected prognosis might be associated with more anxiety. Just a thing to consider in your future work.
That's a really great point. And I think that can also impact the parents' mental health as well, which I've seen can impact the child as well. So thank you. That's a great point.
And then Alex, I think this assessment that you're doing is great and very necessary. But if an advocate were to reach out to you today to say, where can I get some information? What can I do? I agree with you that ACCESS is working hard to try and build this library. Are you familiar with any other potential resources that families or other people with lived experience could be directed to today to try and meet their needs to become more effective advocates?
Yeah, so there are already some courses available. I believe the Canadian Cancer Society has one for advocacy, as well as there are just resources in general for like how to become an advocate, which is like, how do you promote yourself on social media, how to train yourself for public speaking and reaching out for those opportunities. So advocacy is super broad, so there's like a bunch of resources there, but specifically for pediatrics, it's a much smaller space, but there are some, like one course right now that I'm looking at to sort of base my information on.
Great, thank you.
Any other questions before we move on to the next presentations? No. Next up, we have Emily.
Hi everyone, I'm Emily and I'll be presenting on a qualitative study. And so testicular cancer is one of the most prevalent cancers among adolescent and young adult males, and trying to navigate cancer during this stage of life comes with many unique challenges. From gaining confidence and independence to establishing their identities and planning for the future, a testicular cancer diagnosis can interrupt these milestones and have significant physical and psychosocial impacts on patients. However, research has shown that having a romantic partner at diagnosis and throughout the cancer experience helps reduce these negative outcomes, improving the confidence, adjustment, and overall well-being of testicular cancer patients and survivors. Now, while this is great for these individuals, it leaves us with the question, what about the experiences of the partners themselves? In a partnership, whatever affects one person affects the other as well. So when your partner is experiencing something as difficult as testicular cancer, and when you are their main source of support and the person they rely on the most, how does this affect you? This question is what we sought to explore with our study. What are the lived experiences of partners of individuals diagnosed with testicular cancer during adolescence and young adulthood? To explore this, we conducted focus groups with these partners, all of which happen to be women, and through reflexive thematic analysis, we generated 3 overarching themes from the data. The first was that, as caregivers, partners must balance various new roles and responsibility, which becomes a large part of their identity. And if you could go to the next slide, please. Thank you. This theme is highlighted through this participant who said, I feel like I went from nurse, housekeeper, taxi driver, animal caretaker, trying to make sure everyone else was okay, to I don't even know what I like anymore. I bought a couple of books and returned them because I was like, I hate these. What am I even doing? I hate these. The second theme is that women suffer silently with their partner's diagnosis, minimizing their own experiences and emotions due to guilt and fear of being a burden. As expressed by one participant, "It was my husband that went through this. What did I have to really complain about? I wasn't getting the chemo doses, I didn't lose my hair, so I don't have a right to feel these emotions that I'm feeling. It ended up being very, very isolated in my case." Lastly, the third theme captures that partners must confront a future that is different than expected as a result of the cancer experience. In this quote, the woman said, "There's just a year missing from our lives in terms of working towards our goals. We just had to put everything on hold, and we're still recovering from that, and it's hard when this is the time when you're supposed to be working towards your family and saving." Overall, these results demonstrate that partners of individuals diagnosed with testicular cancer are indeed largely affected by the cancer experience. These women face unique emotional and practical challenges when supporting their partner throughout their cancer diagnosis. And to help alleviate these challenges, there is a need for improved support and resources tailored to these partners specifically. Thank you.
Anna?
Hello, my name is Hannah and I'm a summer student working within Theme 5 Education and Training. Do you mind flipping to the next slide there, Jenna? Thank you. And I've received ongoing mentorship from my supervisor, physician co-lead, Dr. Mira Rayar. One of the major projects I've been working on this summer is the development of an ACCESS virtual research program, which will launch in the summer of 2025. And my presentation today, titled Advancing Pediatric Oncology Through Student Engagement, the ACCESS Virtual Summer Research Program, will outline briefly the process of program design and development, the goals and objectives of the virtual program, as well as the benefits that the program is likely to bring to the ACCESS community. Next slide, please. Thanks, Jenna. So in developing the ACCESS Virtual Summer Research Program, I began with a literature search where I explored the structure and design of virtual research programs from various other institutions and health centers, one being the American Heart Association. I then put together a preliminary program framework, and I sought feedback from a working group comprising ACCESS Theme 5, as well as other experts in the field. To ensure that the research program is engaging and relevant to students' interests, we're also gathering feedback from students here participating in the current ACCESS summer experience. And the insights and feedback, both from the experts in the working group, as well as from student participants, will shape the final program outline. Next slide, please. The program aims to provide an inclusive educational experience for students coming from a diverse academic backgrounds. And general overarching objectives include equipping students with research skills in pediatric oncology, fostering networking opportunities with peers and mentors across Canada, and also providing students with exposure to a knowledge of pediatric oncology from healthcare providers, researchers, and people with lived experience, and also providing students with an opportunity to explore a potential future career in the field. The 8-week program accommodates undergraduate, graduate, and medical students and features a variety of components, including a research project and poster presentation, ongoing mentorship, as well as educational content, which will be delivered on Zoom, as well as asynchronous materials. And this content will be centered around professional development and practical skill application. And finally, recognizing connectivity as a challenge with virtual formats, various networking activities will also be integrated throughout the program. Student feedback will be collected through surveys distributed at designated time points, and this is to ensure and check in whether students' goals within the program are being met, and also to check whether educational components are valuable and fulfilling for students. Next slide, please. The virtual research program will likely bring many benefits to the ACCESS community. So for example, mentorship opportunities will allow ACCESS mentors to refine their skills in mentorship, while students are able to develop professional relationships and also receive early career guidance. Students will also join from a variety of locations and educational institutions across Canada, expanding and enriching a consortium with unique perspectives and experiences. And finally, as future healthcare providers, researchers, policymakers, and healthcare leaders, students will acquire a robust knowledge base and skill set in pediatric oncology, ensuring a well-rounded preparation for future careers. Next slide, please. Thank you all for your time and attention today, and I'm more than happy to answer questions or provide clarification in the upcoming Q&A. Thank you.
Thanks, Hannah. Next up is Ernest.
Not sure if my slides are up.
Can you see the shared slides, Ernest?
No. Wait. Okay, I can see. Sorry about that. Hello, everyone. My name is Ernest. I'm a PhD candidate at University of Toronto, also working at ACCESS. Next slide, please. No conflict of interest. Pediatric low-grade gliomas are the most common brain tumors, or based on some resources, the second most common. They're heterogeneous, and if the total resection is not possible, it becomes a chronic disease. Next, please. There are multiple molecular subtypes of PLGGs. BRAF V600E mutation is the worst one in terms of risk, and identifying these two biomarker molecular subtypes determines the treatment selection and risk stratification. Next slide, please. Currently, the ground truth comes from biopsy, which is invasive, might see the tumor slow, and its accuracy depends on precise sampling. So we need to have a non-invasive tumor type detection and subtype identification. Next, please. So for these patients, surgical resection or even biopsy may not be feasible or recommended in over 1/3 of the cases. And we do have a lot of MRI scans, and there are targeted therapies, for example, BRAF targeted therapies or BRAF inhibitors, and there are clinical trials. So that's why we need MRI-based non-invasive pipelines. Next, please. In terms of data set, we started in 2020, and currently we are at 495 patients. It's bi-institutional. It's by far the largest data set in the world for this specific disease. Next, please. There are different ways to formulate the non-invasive pipeline. The simplest one is demographic or clinical information based. We have publications on that. Tumor location, we proposed a project that went beyond what is there as categorical variables. We considered everything at the most granular way. Radiomics, which involves using handcrafted features. We have publications there. And finally, convolutional neural networks and deep learning based models. Next, please. Sorry, can we go to the next slide?
Yep, it's the next slide. Did it advance?
Oh, sorry. My internet connection was frozen.
Can you see it now? Precision
Yes,
medicine?
yeah. So currently we are working with new pipelines, which are focused on precision medicine. In terms of area under the ROC curve, multi-class, of course, we are at 0.82, which is impressive. And we can predict subtype identification for every single patient in the cohort. Next, thank you very much, and I'm grateful to the lab members.
Last but not least, Raisika, I'm sorry.
Hello, my name is Raisiska, and I'm a summer research student at ACCESS-ACCES. And so for my summer project this summer, I was working on helping to develop an onboarding program for ACCESS. And this summer project was on behalf of the ACCESS Consortium. Next slide. So a little bit more about ACCESS. So ACCESS stands for Advancing Childhood Cancer Experience, Science, and Survivorship. It is a pediatric cancer consortium in Canada that focuses on research and getting better access to research, treatment, and care for pediatric cancer patients across Canada. And so ACCESS involves a lot of stakeholders, as you can see here, including people with lived experiences, or also known as PWLE, which includes patients, parents, survivors, and family members. And so one of the things that are needed for ACCESS is an onboarding program to kind of bring everyone together. So next slide. So the first step of creating an onboarding program is a very important environmental scan. And so this is what my summer project was. And so in my environmental scan, I looked for papers in 3 categories, which were people with lived experiences, volunteer onboarding, and patient partners. Next slide. And so for the results of my environmental scan, I initially applied the filters peer-reviewed journals, review articles, articles in English, as well as articles published from 2019 to 2024. And so the results I got were about 4,000 for people with lived experiences, about 923 results for volunteer onboarding, and over 250,000 results for patient partners. And so the next step was kind of screening the abstracts and titles of all these articles by looking at the relevance of the articles to PWLE and how they were involved in research, as well as whether it included onboarding programs that can be applied to organizations that involve PWLEs, and also looking at can the article be applied to onboarding different groups of people. And so after the exclusions, we got 36 articles of interest, which underwent a full text review and were included in a literature review matrix, which then allowed me to kind of analyze and classify the different themes of all the articles together. So next slide. So kind of like the takeaways or the big important themes for all of these categories. So the first one, for people with lived experiences, the main things that the articles really mentioned or talked about was having clear communication between all levels of the organizations and what people with lived experiences have to offer, as well as fostering an open-minded network that is open to all opinions and suggestions. For articles related to volunteer onboarding, being consistent, because it's important to use the same practices that were used for others in similar circumstances, as well as considering doing different mediums of onboarding processes for multiple types of volunteers, for example, doing some group onboarding versus one-on-one. And finally, for patient partners, the main takeaway themes were kind of appreciating what the patient partners feel they have to offer and hope to accomplish, as well as learning more about the patient partners' motivations and how we can align them to our missions and goals. And so a theme that was consistent throughout all the articles is ensuring the value, missions, and goals of the organization is effectively communicated to everyone, and that we reinforce the shared purpose of our roles. And so all this information that was gathered from understanding what was found from the environmental scan will be important information for consideration when the ACCESS team begins to build and develop the onboarding plan for ACCESS. So next slide. Yeah, and I would just like to say thank you to Stephanie Grover, Adrian Kodaya, and Dr. David Malkin for the help, as well as the Survivor Scientist program for this opportunity.
Thanks so much. So any questions for our presenters? Go ahead.
So for Emily, based on your experience in these focus groups of partners of testicular cancer, what would be the intervention that you would most favor if you could do one thing to improve their situation?
Yeah, that's a really good question. I think that like support groups with the partners themselves would be really useful, just the romantic partners, like the women together, because there's just often like a sense of isolation that they feel, and they just, they don't feel like anyone else is going through the same thing, and their friends don't understand. And since they're often younger, like they're just kind of in a stage of life where everything's changing for them. And many of them expressed in the focus groups that there was a therapeutic aspect to it, to feel like other people went through the same thing and that they weren't crazy for having these emotions. And yeah, so I think that support groups with the women would be really good.
So are there plans arising out of your work to perhaps pursue that at in Calgary?
So far there's not, but we're kind of working on just finishing up our results and publishing our manuscript, and then from there, hopefully we can kind of move along with helping these partners. And yeah.
Great, thank you. For Hannah, what are going to be what's the key ingredient for success in a virtual summer research program? Because you don't have that personal, well, you don't have that face-to-face interaction. apparently? What's going to be the key to make that really resonate with people, help them connect?
I think, well, I could sort of answer this based on what I've found in the literature, but also based on my own experience and kind of conversations with the working group. And I think that the opportunities to network within small groups and really feel that you have mentors that have your back and are checking in on you, and are there to sort of prioritize your goals and your learning in this kind of reciprocal mentorship relationship, I think was in the literature, but also based on what came up in working groups. So I think having networking opportunities with peers, but also with mentors, and knowing that you're really involved with an organization, and that people will check in with you and help you kind of along the way, I think is the way to kind of get over that hurdle of feeling somewhat disconnected when it's solely virtual and people are coming from all different places. So I hope that answers your question. Yes,
that's great. Thank you. Ernest, so your work with non-invasive monitoring of pediatric low-grade glioma, is that ready for prime time? Are the people that you're working with using this now clinically to monitor their patients? And if so, how is it being used?
That's a great question. So we are very close to deploying the model for quality improvement and internal use. It's not being used yet. This per patient results I showed are very new. They're not published yet. So I think we are 5 to 6 months away from deployment. The other concern is that so far we have models which are trained based on a cohort, and now we get new patients. The next question is about incremental learning with the new patients coming and with the access to their ground truths. Should we retrain the models? And if we do, what is the impact? So what we did was that we extracted all the dates of study from the MR scans we had, and then we ordered the data set chronologically. And then we started training the model with the oldest patients, and somehow just simulated these coming patients. So that's what we will have on our to-do for 2025. After that, we are ready to say, at least at Sick Kids, we can use this.
Great. Thank you. And finally, Rasiska, so onboarding is really important, but I think ultimately, unless it leads to continued engagement of advocates, that to me would be an important measure of success. Through your review of the literature, did you see any single theme that sort of single element that was really important in successful engagement and continued involvement of individuals who go through this onboarding process?
Yeah, so kind of really communication. Really, they meant a lot of the articles really talked about like making sure there's clear communication throughout everyone in the whole organization. So not only with kind of like the organizers and the people who are being onboarded, but kind of like throughout the whole organization, everyone's able to communicate with each other, and everyone kind of understands the value and the mission and goals of the organization, so which kind of like helps them to move forward and like encourage them to kind of like come back. And yeah,
communication's the key. Great, that's the message. Thank you.
Thank you. I'm just going to check the Q&A here. So this question is for Hannah. I'm interested in participating in the virtual summer research program. Do you know when the virtual summer research program will be? And if someone is interested in participating in that, where can we go?
Great question. Yes, the onboarding application process is sort of still in the works at the moment, so more information to come on that, but it will, the planned timeline will be, the program will launch mid-June of 2025 until kind of early August of 2025, so next summer. But yes, the onboarding and application process is still somewhat in the works. My vision, I think what will be the case will be that information will be kind of sent out from ACCESS to different organizations, academic institutions, and that's kind of how the application process will go, but that's still in the works. So I apologize for not having more information on that, but June to August of next summer is the timeline.
Were there any other questions? So just a big thank you to our trainees. Thank you so much for your presentations today and for your participation in the summer experience. We hope that you enjoyed your time and we wish you all the best in the future. Just thanks again, and I hope you have a great rest of your day.